Okay. So hopefully everybody can see that, I think. So, so this presentation is meant to be a quick overview. I'm going to try to, first of all, I'm going to put the required slide that says I have no conflicts and no interest apparently in anything. And I'm going to give a little bit of the historical background of the osteopathic profession, and then discuss a little bit about the foundations of the profession, that's principles and tenets of osteopathic medicine. And then at the end, I have, as a spoiler alert, what appears to be a big looking case study, but there's only a part of it I want to do to try and illustrate what we mean by this philosophy and principles for you. So the profession, the osteopathic profession in the United States, started in the United States, and was started with this gentleman, Andrew Taylor Still, who, as you can see his timeline here, you can see the lifespan that he had here during that time. He is typically always listed as MD and DO. Historically, actually, when Dr. Still started the profession and started the first osteopathic school, as far as I can tell, he never actually took the DO degree himself. It was, I've lived through the time when it was actually awarded posthumously to him. I don't know, Dr. Pecky, I don't want to date him either, but he talked about my beginnings as a student, and I've been around long enough that sometimes I'm still accused of having breakfast every day with Dr. Still, but I don't go back quite that far. So Dr. Still was born in Virginia, and he was born to his parents, obviously, Reverend Abram Still and Martha Still. Reverend Still actually, Dr. Still's father was a doctor. His dad was a physician, but his main job was to be an itinerant minister for the Methodist Church. In those days, in the early days, really post-revolutionary days in the United States, there were not very many medical schools at the time. The ones that existed were mostly towards the East Coast, a little bit in the Midwest. The western part of the United States was being settled, but still a lot of development to do there. So it was not uncommon for physicians to become physicians by apprenticeship. And this is what A.T. Still did. He spent a lot of years apprenticing with his own father. So you would become an apprentice with a physician and study with them until such time as you felt comfortable enough to move into practice, and then you could get a license and start practicing. So that was a common method in those days. Dr. Still's, and it was also very common in those days with certainly much less population, where oftentimes physicians really had other jobs, if you will. So Dr. Still's father's main job was to be a minister for the Methodist Church. He traveled around preaching for the church, and he was kind of a physician on the side, so to speak. His mother was his mother, but we'll mention a few things in the history here. But in Still's family, the women were very strong and very equal, very much to the men. They managed households, but they managed finances. When Dr. Still started his school, his wife at the time helped manage the financial aspects of the school. And you'll see when I'll show you a picture that in Dr. Still's certainly family life and in his professional life, women were always given quite a bit of equal status in things, in a time when that was obviously a very difficult time for women. He was a farmer and a physician like his father. That's what they did. A.T. Still, from his younger days, demonstrated a lot of interest in how things worked, in the structure and functional elements of things. He was an inventor. He invented quite a few things historically, and invented things like he invented a better butter churn that worked easier and made people's life easier to just make butter comparatively. He invented farm machinery that allowed people to plant crops and harvest crops in a much easier and faster fashion and things like that. He never patented any of his inventions, never took any money for them because he felt that he was inventing things for the people to let them have them and let them have their lives be easier with all the hard work they had to do. Still himself and his family were abolitionists. They were opposed to slavery in the United States and were very active in the political scenarios about that, and also militarily as well. Dr. Still served as a sergeant in the Union Army during the Civil War. So these are some background things that kind of played into his thinking that led him to eventually start our profession. For example, his experience as an inventor taught him a lot about structure and function, which we emphasize a lot in osteopathic medicine. He always liked to see how things worked and find out about them. Over the time, as he practiced with his father and then on his own, he became increasingly disgruntled with the status of medicine, the practice of medicine in his time. In those days, medicine was as scientific as it could be, but still had a long way to go. Still was particularly concerned about many of the treatment remedies that were available to physicians of his time. Many of the pharmaceuticals, if you will, the drugs that they used to treat people were oftentimes worse than the diseases. They were concoctions made out of things like arsenic and mercury and whiskey and opium and things like this. And so in their efforts to help people, sometimes physicians unwittingly made them worse, or possibly made them alcoholics or drug addicts in an effort to help them feel better. Dr. Still's family, his father being a preacher, Dr. Still had quite a religious influence on himself. And he, at one point during his practice, he experienced there was an outbreak of spinal meningitis. By this time, the family had migrated to the Midwest, and they were now in Kansas and then later in Missouri, where Still started his school. And there was an outbreak of spinal meningitis during that time, and 3 of his children died during the outbreak. And Still had been increasingly disgruntled with the inability of medicine to help people as well as he thought it should be able to at that time. And this drove him even further to rethink his whole practice of medicine. He, in his autobiography, he reflects in one section on one of his father's sermons that he used to give, wherein his father would talk about God being a supreme being, and God being a perfect supreme being would have created the world and everything in it the best way it could be created. And now, as a practicing physician, observing some of the failures of medicine around him, he began to wonder whether what was going on, and he pondered, did God leave it to us to guess what was wrong with the patient and guess what the remedy was? That didn't seem like the right way to do things. And so he concluded one of 2 things: either that there was something that we didn't know about the human body that we haven't found out yet that could make the practice of medicine better and more effective, or he considered the possibility that God was perhaps not very good at creating his universe, and why that might be the reason why one of his creations, the human body, didn't work very well at the time. So I guess, not waiting to be struck by lightning, he chose the other alternative and decided he had to study harder. So he went back and he studied anatomy and physiology again. He spent a lot of time dissecting cadavers, and he noted in his dissections that when he saw a diseased organ, something that might have led to the death of that particular patient, he also noticed what he called anatomical obstructions, disturbances or distortions in the musculoskeletal elements that were segmentally associated with that organ through the nervous system. And so he saw these, what appeared to be tissue restrictions, joint motion restriction type of effects in the musculoskeletal system, the muscles, fascia, tendons, ligaments, joint capsules, things like this. And he saw the interconnection between the organs and those segmentally related musculoskeletal areas through the nervous system. So he began to see the whole, the unity of the body, that it was greater than the whole. He began to see this relationship with structure and function, and he began to see the importance of the musculoskeletal system and the structural elements of the body. And his sort of inventor engineering characteristic of himself led him to believe that the human body was quite a lot like a machine in those ways, and that when you put a machine together properly and all the parts are in the right place, then the machine tends to run properly. It tends to run at its best level. He reflected in his autobiography here, shown by this picture, when he was a young boy, that he used to suffer from headaches. And one day working in the barn on the farm, he got one of his headaches and he went out of the barn to get some fresh air. And there was a rope swing on a tree out in the yard, and he lowered the rope and put a blanket over it like this, and he laid down and got himself comfortable. He fell asleep after a little bit, and when he woke up, his headache was gone, and he felt quite good. So being about 10 years old, he didn't think much of it at the time. He just knew that every time he got a headache, he could go out and to the yard or somewhere and put himself in this type of position where he kind of rested his head and neck like this, and he would rest for a while and his headache got better. Now, years later, after all of his experience in medicine and his concerns about the practice of medicine and all the things that he's thinking about, he realized that in essence, he was doing something to the structures here in his head and neck that somehow affected their function. He positioned himself in such a way that he was able to restore a better function in his body, and he got better every time that he did this. So these anatomical disturbances that he saw in his cadaver work, he called them anatomical obstructions. Today in osteopathic medicine, we call that somatic dysfunction. And this is the type of things that we as osteopathic physicians can palpate on patients with our hands and can use our osteopathic manipulative techniques to change those tissues and to restore the motion in those tissues and the normal tensions in those tissues. Dr. Still thought by alleviating those things, he was able to restore and improve the blood flow, the arterial and venous blood flow through the body, the lymphatic system of the body, and to restore more optimal nerve system function. And he felt that by restoring those things, what happened to him was he saw that he was able to get more success with patients from a number of things. And it wasn't just musculoskeletal things, headaches or backaches or things like that, but he had patients with respiratory infections and GI problems and asthma and things like that. And when he would remove these musculoskeletal disturbances, as he thought they were, and he thought that he was improving the nervous system function and also improving arterial and venous blood supply through the body and the lymphatic system's ability to use its immune functions, he saw clinical results in many different cases. So when he put that all together, he felt that he had discovered something that would allow him to get closer to the root causes of disease and have a lot more success. And he had a lot more success on patients without necessarily having to use any of the sort of toxic treatments and things that were available of his day. So he found out that he had to use a lot less of that and sometimes none at all in certain cases. He was very successful with this. He ended up, he was now practicing in Kirksville, Missouri, where he started his first school eventually. He was so successful with this that he had too many patients, essentially. Nearby to Kirksville was a town called La Plata, where the Amtrak train still goes through today. The train across country brought patients out that way, and he had people coming from all over the country who had heard about him and who were having difficulty with regular medical treatments, and so they sought out Dr. Still. He had so many patients that he realized that he had to teach his methods to someone else. The medical community of the time, in spite of Still's success with what he was doing, did not accept his ideas and they just didn't catch on. So he realized he needed to teach his methods. So he opened his first school there in Kirksville, called the American School of Osteopathy, and he opened it in 1892. And he had his first class in the school that included a few of his children, who he recruited to learn his methods and help him then to run the school and assist him with teaching others. Most of the first class were probably people who had been treated by him successfully, and they became so enthusiastic about what A.T. Still called osteopathy. So given that he was doing something that he at first offered to the world of medicine to improve the practice of medicine, he never started out to start another profession. But they didn't accept his ideas, and so he felt he had to teach them. And then he felt that he had to distinguish it by giving it a name, and he gave it the name osteopathy. And that's where that came about. So he started his school in this little place here in Kirksville that looks like this. The picture doesn't give you the real perspective, but if you ever go to Kirksville and go inside the museum building, this building is inside the museum building in the foyer. It's that small. This is a picture of the first class. Just show you very briefly. I mentioned the women in Still's family life and in his professional life. And if you look very closely, I think there's 1, 2, 3, 4, maybe 5 women in the class. So Still had women in the very first class in his osteopathic medical school in a time when it was pretty much impossible for women to try to go to medical school in our country. Unless they developed their own schools and things like that. So he always gave a pretty favorable status to both genders right from the beginning in his school. His first school expanded to what looks a little bit like this now in the United States. This is about the most recent map I could find within the last couple of months or so, I think. So I think it's fairly complete, showing where all of the schools, a number of the schools in the United States also have now branch campuses in different places. So there are actually, I've been told as of July this year, there's something like 58 different campuses where students can go to osteopathic medical school now in the United States. The circles here, I use this in a different presentation, and the circles here represent the Western University where I am and where Dr. Pecha is, and Dr. Young down here in Pomona, which is near Los Angeles. And we also have a campus in Oregon, in Lebanon, Oregon, which is south of Portland, about an hour or so. So we have 2 campuses here on the West Coast there, and there are a few other schools out in this direction as well, in Nevada, Arizona, and also in California. And also schools have now popped up in Idaho, and there's one being developed in Montana. Anyway, it's to the point where there's 100 and some thousand practicing osteopathic physicians just in the United States. The osteopathic medicine is global. Osteopathy was taken over to Europe decades and decades ago by some of the early US osteopaths. And if you look around the world, you'll find osteopathic schools, although in Europe, the osteopaths in Europe and other countries and continents, for the most part, are not fully licensed physicians like we are in the United States. But they are recognized, and they are practitioners of the osteopathic philosophy and the hands-on methods. So what did Still do for us? What did he give us? He used all of these influences on himself to develop what he gave us as osteopathic medicine. The tenets of osteopathic medicine are these 4 things, essentially. One is the idea of the holistic nature of the human body, or body unity. If you look at the history of medicine, there are times when the practice of medicine seems to be more focused on a more patient-centered or holistic kind of approach, and times when it seems to be more centered on a disease-oriented type of approach. For example, the discovery of penicillin led to a large growth in the pharmaceutical industry and other things like that, and technology, because the success of penicillin in treating in certain infectious diseases led scientists and the population to think, well, if there was a kind of a magic bullet for like penicillin, then there might be a similar type of thing for every other disease. So it tends to get the industry and the profession more focused on treatments and these types of things, and a little less on the patient. At other times, there are more patient-oriented things. We seem to live, I think, in a world where certainly the general population now is more interested in the host-oriented or patient-oriented type of work. So the body unity, the sum of the parts is greater than the whole, so to speak. Still, given his cadaver studies and his success with his treatments, he felt that he could put the body in a position where the body's own systems could take over and keep the body well and healthy and keep it regulated that way without necessarily interfering with it too much externally. So he believed that there was self-regulation and self-healing in the body. He saw the interrelationship of structure and function, given his discovery, if you will, of these anatomical disturbances, as he called them, or what we call somatic dysfunctions, and their influence and relationship to health and disease processes. And finally, the fourth tenet, if you will, of osteopathic medicine just simply states that any type of rational treatment is based on the application of these three fundamental principles in the design of the patient's treatment program. So body unity, the patient has a disease, the disease does not have the patient attached to it. Okay. And self-regulation and self-healing are important. And we believe that as DOs, we don't oppose, obviously, the use of prescription medications, surgery, technology, these types of things. The idea is that we want to look at the patient and see how well can we optimize the patient's own self-healing and self-regulation capabilities. That helps us to determine what other interventions we may need and how much of them. And we believe that that gives not only a safer, more efficient approach to the patient, but clinically, observationally, seems to give them longer lasting results sometimes, and a more optimum level of health and wellness. And the interrelationship of structure and function, and still, as you know, developed his hands-on techniques, which we now call osteopathic manipulative treatment, to treat these somatic dysfunctions and help his patients. And of course, the rational treatment based on applying those principles. Somewhere in the early to mid 90s, some people in our profession kind of revised a little bit these tenets and proposed this as a sort of more updated description of the osteopathic tenets and philosophy. And the basic tenets are here in this sort of red or burgundy color, and some sort of philosophical, or the tenets are here in the more yellow numbered or dark print, and there are some principles attached to this to make it more patient-centered, if you will. This is not opposed by the American Osteopathic Association or the profession at large. Everybody agrees with this, although the American Osteopathic Association here has not officially designated this as the official description of the tenets of osteopathic medicine. And again, not because they're opposed to it, but those four principles that I explained in the previous slide, they're shorter, they're more to the point, and sometimes realistically, it's much easier and clearer to speak to the public or people outside the profession and explain to them about osteopathic medicine using those four shorter principles and then embellishing with this later on if you need to. But osteopathic medicine has had this written set of principles and philosophical components ever since the beginning of the profession. Another way that we look at this today is that if we think of everything that's living, a common denominator to just about everything that's living is motion. Things that are alive seem to have motion to them. When in the days when I was the young DO and all the other DOs were the old guys, they would say to me, remember, life is motion. Motion is life. This was sort of the osteopathic adage. And and Dr. Irvin Kaur, who was a PhD physiologist, one of the foremost researchers in our profession, and he's considered to be the second greatest osteopathic philosopher, next only to A.T. Still himself. And Dr. Kaur described this as what he called the primary machinery of the body, meaning that in the human body, we start out with a skeleton, so we have a skeletal system, and on this skeleton, we have our muscles, fascia, ligaments, tendons, joint capsules. We have all these structural supportive components. So we have a musculoskeletal system, which is, we all know, is a large system collectively in the body. It's a very energy demanding system of the body. And Kaur described this as the primary machinery of life, meaning that when we see each other and we observe each other on a day-to-day basis, this is what we see. We see each other. We see this primary machinery in action. This is what we use to accomplish what we do every day in life for ourselves. The viscera, or internal organs, we think of as the secondary machinery of life. And it's not to mean that they're less important in this category, but from the osteopathic viewpoint, the collection of internal organs and viscera, their overall job is to take in nutritional elements, oxygen, medications, bioactive substances, whatnot, process them, and make sure that all of this is distributed to all the tissues of the body. And then through the venous and lymphatic systems, all the metabolic waste products of these metabolic processes are removed properly. And their job is to function, to provide this fuel, these elements, if you will, so that the primary machinery can help us carry out whatever we need to do on a day-to-day basis. And the viscera adjusts itself depending on the demands made by the primary machinery. So it's kind of the view that, in general, that we might have in very broad sense of the human body and how it functions. These two systems, if you will, primary and secondary machinery, are coordinated through the nervous system. So as we all know, we have a central peripheral system, including the autonomic system, and osteopathic medicine puts a great deal of effort or emphasis on the autonomic system, because it's through our hands-on approaches and other things, we know that we can affect the nervous system in a way that we can affect physiology sometimes, and we can help to restore the body's functions by removing any disturbances through these systems. So this is to illustrate maybe one other difference in osteopathic thinking. This is a common page out of most anatomical atlases that we've all been familiar with, and we see the nervous system illustrated here, and particularly all the autonomic structures here. And we all recognize this as something that we have all spent countless hours worrying about and stressing over in school, to learn about all the organs and diseases and conditions involved in here. All of these common figures also somewhere over here usually have this little picture of the skin and subcutaneous tissue, and maybe a little muscle or something with one, hair follicle in it. And the implication is there's all this activity that's very important in the nervous system, and it sort of goes over here too. Kind of has that sort of emphasis like that. This is a diagram from one of Dr. Kaur's articles where he shows the same thing. Here's our central and peripheral nervous system and all of our autonomic activity again. and we see all of the important activity going on that we're always certainly rightfully concerned about and trying to address in patients when they have problems. But CORE is trying to illustrate here, if we take this neuromusculoskeletal system, if you will, all of these components, and look at the massive size of it in the body. So all of this is just as large as all of this over here on the right side. And in osteopathic medicine, we think it's almost just as important. So when you have a diseased organ, sensory information comes in, motor information comes out. When this information gets into the spinal cord, there, as we know, are interconnections where the same nerve roots that come out of that spinal cord that go to, say, the liver also have branches that go to the structural musculoskeletal that are segmentally related to that organ system. It helps us to see the referred pain from those kind of things. From an osteopathic point of view, not only is that going on, but it can become established in a way that that we call it a facilitation in the system, or you could also use the words central sensitization sometimes, or wind up. It's a similar type of process. And these are the things that still saw as anatomical obstructions. These are the things that we can palpate. Not only do you maybe get referred pain, but you can palpate these changes in these segmentally related areas. And as DOs, our palpatory skills can help us in difficult cases to determine the exact segmental relationships, sometimes help us determine more clearly the exact diagnosis or the exact origin of the patient's problem when it's difficult to find sometimes. And by relieving these problems with our hands, we take away this excess nervous system activity going on with the patient's condition, and we take away just the additional energy demand on the body of that condition from this part of the patient's disease process. So when everything is synchronized, as we've been talking about, we have what we call health or homeostasis. Over the years, I started to wonder whether we should call it homeodynamics. I don't know, sometimes it's a semantic thing, I suppose, but sometimes I feel like the word stasis doesn't sound good unless you're trying to stop a nosebleed or some type of abnormal bleeding. So we like motion rather than stasis more commonly in most situations. When something goes wrong with the patient, not only does it manifest in typical signs and symptoms, but we also get a somatic dysfunction associated with it in most conditions. And the somatic dysfunction manifests itself on the musculoskeletal system by what we call autonomic reflexes. And the most common ones that we tend to talk about in osteopathic medicine are here, what we call viscerosomatic or somatovisceral. The viscerosomatic reflexes simply basically means that something is going on with an internal organ, with a viscera somewhere in the body, and in addition to the typical signs and symptoms, is also being reflected in the neuromusculoskeletal system somewhere, usually in the same regional segmental area that's innervated to that organ. And we can palpate that. So it's very much sometimes, if not the same, as what you might think of as referred pain. Okay, so as we know, a patient doesn't usually necessarily come to the emergency room and say, "Boy, my heart is killing me." They say, "Boy, I have pain in my jaw. I have pain in my arm. My chest feels like it's tight. Somebody's sitting on my chest." They express their discomfort by something on their body wall. And if you are the emergency room physician and the patient saying that, you will take that complaint of jaw pain or arm pain or chest discomfort very seriously until you can prove one way or the other whether something serious with the cardiac system may be going on in this patient. Similarly, if a patient has a renal stone, they usually don't complain about their kidney, they complain about their back pain or groin pain or something like that. So it's a very similar kind of idea. Referred pain also has palpable changes, particularly along the spinal column with it. The other thing we commonly see is something called somatovisceral reflexes, which is a little bit of a turnaround, meaning that there's been some injury, trauma, or something to the musculoskeletal system that somehow reflects or influences the functions of some of the internal organs. So, for example, we can have a patient, for example, who has an auto accident. They have a rear end auto accident, and they get a little bit of a whiplash type of injury. So these patients understandably have headache, neck pain, upper back pain, sometimes even low back pain from these things. But patients sometimes will also complain not only of those things, but say, yeah, my neck hurts, my head hurts, there's ringing in my ears, my vision seems a little blurry, I feel a little dizzy, my neck and upper back hurt, I even feel a little nauseous, that kind of thing. So the trauma to their body wall is disturbing some of the functions of their internal organs in that sense. So if you palpate along those spinal areas, it may be intense enough that when you palpate those tissues, it might actually reproduce some of that nauseousness or other things that the patients are feeling. So these are the most common types of manifestations that we see. So
I did just want to interrupt and say we're coming close to that 15-minute mark, 15 minutes left.
Right.
I wanted to make sure we have time for you to end at a good point and wrap up the presentation and also have time for questions.
Okay, I'll move ahead real quick through a couple slides and finish up then. All right.
Beautiful.
Okay, so we know that the musculoskeletal system can reflect pathophysiologic processes. It can affect the processes with these interactions. And it's an entry point for us in evaluating and treating patients, particularly in difficult cases sometimes. This is just this little schematic. We have a patient who's well. We're always under stressors, which tend to decrease our capacity for wellness. But as long as we have enough resources, we can return to wellness. If we continue and don't have enough resources, we tend to develop signs and symptoms of illness. At that point, if we treat just symptomatically, we can get people a little better, maybe, but never back to wellness sometimes. Whereas if we have all the adequate resources, we can try to return them to wellness. So the whole point of osteopathic medicine is to try and get to the root causes and develop treatments to get people well to stay well. So we could, if you want to really sum this up, I think if we want to understand what it is that's obstructing the patient's health, whether it's musculoskeletal problem, whether it's a diseased organ, whether it's stress, whether it's some other type of issue, what is the obstruction to their health and wellness, and how can we help them get over it? Okay. And we do this, we have a mnemonic that we call the 5 models. So this is the kind of thing we try to teach our students to think in terms of biomechanical, respiratory, circulatory, neurological, metabolic, energy type things, and behavioral or biopsychosocial issues. If we keep these principles in mind, we can often ask enough questions and find out. Every student has some sort of mnemonic or device that helps them to remember to ask enough questions with the patients. And we try to get our students to think through this one as much as possible. I'm going to do this very rapidly then. This very case thing is, this is simply, it's not the case so much as some of the elements. A 54-year-old gentleman comes to the emergency room with fever, cough, some difficulty breathing for 3 days. He's lost his job. He's living with family now. He took some old antibiotics for a couple of days and didn't get any better. We've gone through this whole thing. His family has some history of some problems, including diabetes. He's a smoker. He's sedentary, doesn't eat well. So I'm putting this in here. We can see that he's a little overweight. His blood pressure is up now. He's got fever. The obvious thing here is it looks like he has a respiratory infection, probably some type of pneumonia. And the straightforward thing is we'll do an X-ray, probably try to culture him because he's already taken some antibiotics for a couple of days that may or may not have helped him. And we should be able to get him better. But from an osteopathic point of view, we want to, I'm going to move through this not to frustrate you, but they're mostly structural findings in here. And I put this in here purposely, I used to use this to teach students, waiting on an x-ray, some lab work, and some culture. So we pretty sure we have pneumonia. We have the somatic dysfunction findings. We know he has hypertension. The beginning says he has captopril. He came to the emergency room. He has a blood pressure medicine, but he must have a doctor somewhere. Then somebody had to give it to him. He's lost his job. Is he under stress? Is this why he took the old antibiotics? Because he lost his insurance too, and he was afraid to come to the doctor up until that point. I'm thinking of all these things that I can probably treat this guy with the appropriate antibiotics and get him better. But I want to take all these things into consideration too, and at some point in a realistic fashion, help him address these things so that not only do we get him over his immediate problem, but can we get him on a better road to better health and better wellness so that we can avoid some of this in the future. His job loss and things that had put him in a position where the stress of the whole situation maybe made him less resistant to catching this disease that he has right now. Yeah. So as we all know how to ask how the patient is sick, that is, what's their diagnosis, what's their problem. From an osteopathic point of view, I want to know why he got sick. If I can help him with that part too, maybe we can find ways to help him avoid things in the future so that he won't get so sick. I sometimes tell my patients that my job is to make you well and keep you from getting this problem in the future. And my job, in essence, is to put myself out of business if possible. You shouldn't need me so much. Okay, so, and to express this type of philosophy, I think I can put the 5 models across here. I can list my problems with patients here, and I can outline what I'm going to do. The problem with osteopathic medicine, if you will, is it's easy to see a DO doing manipulation, but osteopathic medicine isn't just simply medicine with OMT added. It's a whole thinking and philosophical process, and you can't see people think very well. But if I put my thinking out on something like this, my students tend to understand a little better what the osteopathic thinking and philosophical approach is. So I know that's rapid fire, machine gun fire, I'm sure, but I'm going to stop there and thank everybody, and then I can, I see a couple things in the chat. Are they questions? No.
Well, Dr. Hruby, while our audience is formulating their questions, thank you for that. Yeah, indeed, rapid fire summarized version of a massive
to rush through that.
topic.
I did see something in the chat, Greg, that the question was, where did Dr. Still live? He was born in a place called Jonesboro, Virginia. His father, being an itinerant minister, was assigned by the church over time through Tennessee and into Kansas and eventually into Missouri. And he settled in Kirksville, Missouri. And that's where he lived out the rest of his life. And that's where he started the first osteopathic school. So.
Great. I'll ask a question, a quick one, kind of circling back, as the saying goes, to the concept of obstruction to health and the case presentation. How would an osteopathic physician holistically approaching this 54-year-old gentleman throughout all the systems of concern for him, both the hands-on portion and other medical treatment? What would that look like?
That would be there. That would be. I think I'll put it this way. I think one of the things we have to consider too is the realism of medical practice. When you look at that, it would be ideal if this was your patient or mine. I think you might agree that it would be ideal if that person came to your office today, that you had the 2 extra hours to spend with him to do all this stuff. And that's not going to happen. I would be focused on his immediate problem is this respiratory problem that we have to take care of for sure. I would like to explain a lot of these things to him at that time. I could find some time to do some hands-on treatment for him today, along with the visit. I'd want to follow up on him appropriately. And if possible, I'd like to try and find some arrangements for him to come back at a time when we could spend a little more time and he could get a little more patient education and maybe put him in touch with the resources. Do I have a nutritionist that can talk to him? Now we have the problem where if he's lost his job, does he not have insurance at this time? I would be thinking so far as, do I have to get him in touch with people that can put him in touch with community resources? Can he get on insurance somewhere else somehow? Can I help alleviate that stress factor in his life? So it's not a one-stop deal, and it would be unrealistic to think that you could straighten out his entire life in one visit on that day, especially when he has fever and he's uncomfortable. His attention is not going to be very good. So I'd like to do as much as I could that day and get him feeling better and follow up with him and suggest to him at that point, when you feel better and we come in, we can spend more time thinking about maybe what things might have caused you to become susceptible to this problem and how we can avoid them, and what other things I can suggest to you to do. More exercise, eating better, better compliance with medicine. Things like this that we probably have to address with him. Some of which are going to be biopsychosocial issues too.
Mm-hmm. Great, thank you.
Great question.
Yeah, sure.
The question is, I'm very fascinated by palpation in terms of doing that as not only a physical examination, but a treatment. It's both examination and treatment. Do you go as far as acupuncture, which seems to fit the same idea of the nervous system and intervention zone, but does acupuncture fit into osteopathic medicine?
It can fit in as another modality to help treat people, especially if you understand acupuncture in that regard. I have studied some acupuncture, and I studied acupuncture. Certainly, I'm not anywhere near the expert of some of the people I've seen do acupuncture, but I sought out a course in acupuncture that would teach me a little more of the Eastern medicine type of diagnostic approach and stuff. It wasn't just a weekend cookbook type of acupuncture course. So if you understand the meridians and their effect on the body, then it can be almost as useful as this kind of palpation and treatment thing, and can be used in conjunction with it. I used to use some of my acupuncture treatments with my patients, especially in patients where if they could lie on the table and I could put acupuncture needles in points where they could lie supine for a while, then I could actually sit with the table and treat them with my hands as well while the needles were working and things. So there are a lot of DOs that use acupuncture with their hands-on treatments as well. Yeah.
Okay, thank you.
Mm-hmm.
Okay. Any other questions, comments? Just
questions, comments, or smart. My partner used to say, "Are there any questions, comments, or smart remarks?"
Or wisecracks. So
yeah.
I'll kind of pose one final question on that. It has to do with our international audience and the fact that this may be some new information for them. My sense is that there may be similar histories of movement in this direction in different cultures and different countries. I'll ask you the question, and in your prior role as president of the American Academy of Osteopathy, what does that look like on the international global scale, and what impact has American osteopathic medicine and philosophy had on other continents and countries and their healthcare delivery as you've seen it?
Yeah, well, the American osteopathy, one of the earliest, probably the earliest was there were some DOs who shortly after they trained with AT Still in the next decade or so, they were the ones that there were several brothers that started the what's now the school in Chicago, and one or two of them actually eventually went to England and found themselves introducing osteopathy to England. And there's been schools in England ever since, and schools have popped up Europe, Australia, in Asia, lots of places. In most of those countries, the roots of osteopathy in those European osteopathic schools or international osteopathic schools, also in Canada and even in South America. The roots are American osteopathy, but in most of those places, they have chosen actually to develop the osteopathic profession, focusing on the philosophy and the principles, and they focus mostly on the hands-on approach. It's sort of like they will use their hands-on approach and work with the patients and use the standard medicine, if you want to call it that, and other things as consultants with them, you know. So they don't, but they have chosen not to go the same route we did in the U.S., where in the U.S. we became fully licensed physicians as well. So in most of those countries, the osteopaths are that type. They go to school for 4 or 5 years and learn osteopathy really in depth. But they will be the ones that will be astute enough to treat their patients, but also recognize that they need medical consultation or something like that. And then they work collaboratively.
Great, thank you. Appreciate that.
And there are also things in other cultures that you mentioned too, Greg, that, and I can't say I know very much about them, but you know, Jim asked about acupuncture. If you look at in England, there were people called bone setters. That yes, they could set a bone, if you will, if you want to think of it as a sprain or a fracture or subluxation, but they did similar types of things. And I know in some of the Asian cultures there were hands-on techniques, and I don't recognize necessarily the names of them, but there are a lot of similarities in other cultures. So yeah, you can look around and find people that in more than one place that thought in the same direction that AT still did, I guess. Yeah.
All right. Thank you. All right. Well, I'll give this back to Alexa. I think she has some closing remarks and an announcement